Hi everybody, Tiffany and Deb reporting back.
Hello.
And this topic, we both went to the session. So the session was individuals at high risk of rheumatoid arthritis, a new treatment frontier. It was a debate. So
Woo!
I know, super exciting.
Love the
and
debates.
The question that was posed was treatment with DMARDs should be given to people at high risk for RA to prevent RA? So the first,
I like how you went up at the end.
So
That's good.
So the first person, he was saying yes. So this is the yes side. We're going to start with that. And this has been known for over 500 years. He actually had a quote from back in 400 to 500s. The point was, those who do not recognize and fight disease early risk losing everything. So they knew this a long time ago. So here we go.
So first, just to define DMARD, they were talking about early intervention to RA. And I want to preface this also. So DMARDs are disease-modifying agents. So it might be your first-line treatments like methotrexate, leflutamide,
Sulfasalazine.
Thank you. Or it could go up to a more advanced type of agent like a biologic, JAK inhibitor, that type of thing. And so there's been many studies over the last few years that we've been at these conferences on can you prevent RA? And that's usually where most of these start because RA is one of the more easier to study. So that's why you see a lot of these kind of novel things in RA, but also in lupus because it's a complicated. So they try to pick a couple so that they can better apply it to other diseases. So in saying that, we've seen these, and so they wanted to have a debate on should we intervene on these. So they started by going through the history of we've been in this early treatment of RA. We should be doing it for years now. And even back in the early 2000s, we started moving from a model of kind of this wait and watch approach to what we call treat to target. And so with the treat to target, that's really focusing a lot on working with your rheumatologist to figure out the best treatment for you. And with that, that's okay.
Yeah. Sorry, we've got our slides over here that we're just whipping through as we go. Treat to target is where we want it to go. But actually what we're talking about are the risk factors that are leading up to how complicated, difficult to treat can be.
So to set this up to the debate, after they went over the history, then they wanted to give us, okay, so difficult to treat and risk factors. How are they going to debate on whether it worked or didn't work to prevent RA and should they intervene early or not? And so when we say difficult to treat, by definition, that is if you have failed 2 of biologics with the same mechanism of action. So that means 2 TNF inhibitors like a Humira and an Enbrel. And that is what they define as difficult to treat.
And as far as the risk factors that lead up to this and environmental factors as well, but smoking prevalence, obesity prevalence, and what they actually mostly focused on was being ACPA positive. That was a big part of what they were describing as the risk factors.
Which is a biomarker that you may have heard us talk about a lot as well.
Oh, yeah.
So we've also reported back many times on all of these kind of what an onset trigger, what makes for worse outcomes. And so even though the definition of difficult to treat is if you failed XYZ, what really you're difficult to treat because you have more severe disease. And so those risk factors are the people who have all of those things are the ones who tend to have worse outcomes. They tend to have more aggressive disease. They have more aggressive disease at onset, which I think is an important note here as we talk about, do you treat somebody early with a biologic? Or methotrexate.
Yeah. As far as encompassing the whole piece, it's like at this point, we should also ask the patients whether they would prefer to be considered difficult to treat or would you rather be treated early. That's what the crux of that comes down to. And again, I am difficult to treat and frankly, I'd rather be treated early, but stay tuned. There's also early intervention that can significantly alter the disease course and improve long-term outcomes, like prevention of joint damage, improves physical functioning and symptom relief, reduction in disease burden, delay in disease onset and cost effectiveness, which was honed in on a little bit as well.
And with the cost effectiveness in particular, what they're really talking about is the idea if you treat early and you go into remission, then isn't it a cost savings after all? But then there was the counter of cost savings as well that we'll talk about too in the not for treating early.
And he also focused on 4 studies. And Tiffany's going to tell you what 3 of the studies, a real brief description of what those 3 studies were.
Sure. So one of them was using methotrexate for a year. And you have to put in the context here that these are, so he was saying, look, there are studies that were done to see about prevention. And the point here is, yes, it is true that the prevention trials that were done over the last few years to prevent did not actually prevent. It did delay the onset.
Right.
So he was focusing really on the ACPA positive, what we could do to help the difficult to treat only, not the whole world of RA and prevent the whole world of RA. He was really like, can we really, he focused really not on the prevention, which was in the question.
Yeah.
He focused more on, can we help people with difficult to treat? So I just want to put some context there. And so the first one was a methotrexate, which was on a year, and they had both ACPA positive and ACPA negative patients in there. So again, ACPA positive being typically worse outcomes who would lead to difficult to treat. And there were the ones who were ACPA negative. So it actually reduced the progression in those who were ACPA negative. But the ones with ACPA positive, it didn't really do much for them. But then when we did other studies, 2 different ones that used abatacept, which is also called Orencia, one was for 6 months, one was for a year. In those in particular, they had better outcomes for patients who were ACPA positive. And so it did not prevent, but it delayed up to 5 years. So as of today, which is May 2025, they know that they can delay onset of RA for up to 5 years. And so that was with use of the biologic over the methotrexate. And so what does that mean? That means that potentially those people who were delayed onset got 5 years back, but also they potentially may have better quality of life and outcomes long term by being treated early.
Yeah. So his conclusions were to treat patients with DMARDs who are at very high risk of developing RA using the EULAR and ACR criteria that can delay the onset of the disease up to 5 years, improve quality of life, reduce overall costs, and reduce difficult to treat prevalence or even delay. So that was his first conclusion. And now we're going to go to why you would not want to treat early.
So basically, she came up and she said, okay, the theme of the debate is to prevent. Would you treat early to prevent? And she reiterated, there are no studies that show you can prevent. So that's where I was saying again, and I even leaned over to Deb in a question because I had it written in there. I'm confused because none of these statistics are talking about prevention, and I knew you couldn't prevent.
Yes.
So I think the name of the debate was just wrong.
And we said there needed to be a different question because,
So in saying that, we're going to move, so they were debating about something that was the wrong question. And saying that, she really said, look, here's the bottom line. None of the trials they've done can prevent it. So if we're just talking about delaying it and not preventing it, is it worth treating patients early on where for 5 whole years, I'm sorry, I'm going rogue because
good.
I just
good. I'm catching up.
Of 5 whole years, and then some of them wouldn't progress at all. So if we're treating all of these people that are at risk, then isn't that a costly thing? Because we're going to treat all of them, and we know only 50% actually would develop the disease because that's what because past studies have shown.
Right.
And then in his rebuttal, he says, you just proved my point, because I'm not talking about all. I'm talking about difficult to treat, which is
Right.
really only a very tiny percent
Yes.
of the bigger RA population. And she also cited one of the trials that was on methotrexate, saying, see, you didn't do it, it didn't do anything for difficult
Right.
to treat. And he's point taken. That's exactly what I meant. I meant treat with biologics, because that's proving that there has been some disease impact, with the ideal situation being, okay, you treat early, you actually go into remission. That's the ideal. But her point, maybe we treat for 5 years, nothing happens, and you keep going. And so that's really just looking at the worst case scenario. In
Right.
my opinion, that wasn't a strong debate argument.
Agreed.
So that was really the crux of the debate. And so then they all had a chance to do rebuttals. And essentially, the other thing he said for his rebuttals were that when we're talking about methotrexate versus biologics as well, why would you ever really even consider starting with methotrexate if there's a possibility with somebody so aggressive, or could be so aggressive, knowing that they're going to have such a complex situation long term, comorbidities, all these things we know that happen, right? If we can treat them early, why would we do methotrexate too? Because he told us, and this was something that we're going to admit we weren't completely aware of.
Yeah.
He said only 30% of people will respond to methotrexate, and that methotrexate will not renew the bone damage, but biologics can reverse damage. We honestly didn't know that
at all. And I'm also wondering why we're not being informed more about that. So we looked it up and we found out. So while methotrexate efficiently manages rheumatoid arthritis and helps prevent further joint damage, it does not typically promote bone renewal or reverse existing bone damage. Biologic drugs, on the other hand, have shown potential in reversing bone loss and improving bone density in RA patients.
So there you go.
Yeah.
So in summary, his rebuttal was just, again, I'm not talking about the whole RAs. I'm talking about a very small percentage of people with all of these potential to develop it, to have worse disease. We know what happens with worse disease. We know how to prevent worse disease. Let's prevent this from happening.
Yeah. So conclusion was her side did win as far as not treating early. But again, from my perspective, I was still on the other side.
To note, because I believe it was because the question was to prevent.
Yes, great.
It was hard to say, for some people to say yes, when the whole debate was actually not about prevention.
Yeah,
So
I know.
I just think that it would have potentially been a different outcome if the debating question was slightly different. I do just want to reference the audience did have opportunities to also step up, and I was literally going to go up to the mic and say the same thing. So I was glad actually that a doctor did it, because it was just a better situation in a doctor debate for a doctor to say it. But one of the audience members just said, basically, in reality, what we need to look at is, okay, we know we can't prevent, or as of right now, we know we haven't been able to prevent. We know we can delay up to 5 years if we use a biologic early. And let's not think about, oh, it could cost so much more if a patient's on 5 years, then nothing happens. We know early treatment does better.
Absolutely.
So if we're able to at least make disease better for a difficult to treat, then we should consider that. But he said the model's wrong in the way that it was presented. What was left off, which I wrote, and I was thinking the same thing, was we also know in those same studies that once a patient went off of a drug, if they started to flare, when we're talking about the tapering ones, we know from those research, when a patient starts to taper off of a drug, that they all flare, or most of them flare again, and you do microdoses. So he said this argument really should be, why don't we do early intervention? We should expect someone difficult to treat to do a little better and then come down, microdose them, and then maybe we get the optimal remission. And I thought, yes, that would be the point that everybody would say yes
Agree.
to.
And also biomarkers were really brought up, as well as taking advantage of some of the science that's out there.
So there you go. What do you all think? What would you do? Even though, again, thinking that, if I'm going to rephrase the question, would you do early early biologics, what would you want? If you knew that you had all those risk factors, if you knew that you were a strong candidate to be a difficult to treat patient, would you want to have the opportunity to use biologics early? We know there's issues with actual prevention part of it,
Right.
but even if you could get it early, would you want to do it?
We'll leave that right there.